So I want to welcome everybody to the first grand rounds of the year. We have a pretty full schedule over the coming months, and you'll be able to see that in the next slide or two. You'll be able to see the next couple of grand rounds we have. But I'm really delighted to introduce today's speaker, who happens to be our newest faculty member. And Jamile Shammo from Rush joined us just, I think, a few weeks ago. She's still getting oriented, but Jamile has been around Chicago for a long time. She completed her residency in both medicine and pathology here in Chicago, and then subsequently, specialized in hematology oncology and worked her way up the ranks to professor at Rush. And we were fortunate enough to recruit her and entice her to come over to Northwestern. And I think she's going to be a fabulous addition to an already very robust classical hematology group. And Jamile has an interest in a variety of things, including benign heme, obviously, but also specifically trying to develop further a bone marrow failure program here at Northwestern. And I look forward to the contribution she's going to make over the coming years. So I think it's no more appropriate than someone like Jamile to start us out, a new year, new directions. And we look forward to your talk on paroxysmal nocturnal hemoglobinuria. Jamile?
Thank you, Bill, for the introduction. I am delighted to be able to join a group of at Northwestern, and glad to be the very first presenter for the grand rounds. I think there's been a lot of changes in our understanding to PNH, and some of the novel therapeutic agents that have also emerged. So I think it's only appropriate to have a discussion about where the field is going when it comes to PNH therapy, and how will this look, let's say, in the next 5, perhaps to 10 years. Let me see if I can pull my slides. There we go. So no talk on PNH is complete without mentioning the historical perspective and how things changed in terms of understanding this disease from the very first time the case was reported by Strubing in 1882, to understanding that those cells are very sensitive to lysis by an acidified serum, followed by the actual discovery of the alternate complement pathway, which explained why those red cells were actually hemolyzed and antibody-independent like factors. Then it was the realization that, look, PNH cells occur in a milieu of bone marrow failure, and so perhaps those cells must have an yet ununderstood biological advantage. Later on, it was noted by Wendell Ross that actually PNH cells were 25 times more likely to lyse by complement, and that they had a lot of C3 binding. Later on, Lozado discovered that those cells tend to be clonal by G6PD isotyping, but it wasn't until the 80s until CD55 and 59 were discovered as the main proteins that are missing actually on the surface of red cells that lead to their destruction by when the complement activates. And in 1993, the actual somatic mutation in the gene that is responsible for the formation of the GPI anchor was reported by Kinoshita in Japan. So this gene, the phosphatidylinositol glycan class A gene, is responsible for the production of what we know as the GPI anchor. And the gene resides on the X chromosome, essentially. So it's very important in the rate limiting step of forming the anchor. And the anchor is essentially the structure that you see here. It's a lipophilic protein. So the lipid part inserts into the cell membrane. And on the other side, it carries a variety of proteins. Up to 150 proteins have been described to associate with the GPI anchor, which, by the way, exists in all the way to eukaryotes. So it's a structure that is essential for cellular function. So two of the proteins tend to be extremely important in the pathophysiology of PNH, and those are CD55 and CD59. So when they are lost due to the loss of the ability to have that structure, then you end up with destruction of the red cells by the complement when it activates, leading to intravascular hemolytic anemia. And since this is a complement-driven disease, I think it's helpful to also understand a little bit about the complement and how it activates, because this is essential in understanding not only the mechanism of action of drugs that we have available right now, but also in understanding some of the novel agents that are being developed for the treatment of this disease. So the complement system is part of our innate immune system, unlike B lymphocytes and others that need to be educated by exposure to certain bacteria, etc. This system actually is reflexive. So it's intended to protect the organism from invading bacteria, fungi, etc. So the classical pathway activates with immune complexes. The lectin pathways, when it gets activated by highly preserved bacterial products that contain mannose. So there are certain situations that lead to the activation of those two pathways. On the other hand, the alternative pathway that was discovered by Pellemere, which is antibody independent, this part is activated constantly by hydrolysis of the C3. So you constantly have C3 particles that are being produced, and then they get cleaved by factor B and factor D. So factor D cleaves factor B, and then you go on to the cleavage of factor C. So it's an ongoing, constantly agitated system at a low level, intended again to protect against bacteria and fungi. And the complement intends to keep the all the non-self particles expelled from the system by the formation of membrane attack. But whichever way you end up activating the complement, it all converges on cleavage of C3. Once C3 is cleaved, then you form C5 convertases, essentially a group of proteins that are capable of cleaving C5. Once you cleave C5, then this is considered the terminal complement cascade, i.e. the point of no return. And then you end up with membrane attack complex that creates or punctures, makes holes into whatever cell is trying to destroy. And that is the intravascular hemolysis. Now, importantly, I need to show you what happens when you have the CD55 on the surface of the cell. So CD55 is known as decay accelerating factor, and in that sense, it destabilizes C3 convertases so that you have fewer and fewer activated C3s that go downstream. And CD59 also sits on the surface of a given cell, making it difficult for the formation of membrane attack complex. So you can understand in the absence of those two molecules, what happens, and I hope this works. Here you go. So you get all those C9 deposits, and that's what creates a hole inside of a red cell, leading to its destruction and all the consequences of intravascular hemolysis. This is an electron microscopy of a red cell, showing you again all those holes, essentially the effect of a membrane attack complex. So this is the process by which patients who have PNH manifest. This is a very rare entity, and the incidence is reported to be 1 to 1.5 cases per million. The prevalence is perhaps 15 to 16 per million. It's not a very common entity, but perhaps it is underdiagnosed because often people don't even think to do the diagnostic testing for this. And it can happen in patients with in their mid-30s, perhaps. But in children, which represent maybe 10% of all PNH cases, it tends to manifest in the teenage years. And it has perhaps a different flavor in that it has a little bit more of a bone marrow failure rather than a hemolytic feature. So PNH tends to overlap with many of the bone marrow failure syndromes that we have. So you have to think about it when you have patients of aplastic anemia, MDS, hypocellular MDS, LGL, granite, and then there are certain I've seen case reports with MPN and PNH, but nevertheless, so you have to think about it in cases where you have bone marrow failure. And I have seen also progression to leukemia, perhaps when you have patients who have MDS and clonal evolution resulting in that. Fortunately, that transformation rate tends to be rather low. This is the classical triad of PNH, where you have intravascular hemolysis, hemoglobinuria, and this tea-colored urine in the morning, propensity for thrombosis, and this picture is simply that of Chiari with all those little dark particles into the vein, and then accompanied by various degrees of bone marrow failure. But classically speaking, I should say, you really don't see that triad in all patients. In fact, hemoglobinuria has been reported only in a quarter of patients at the time of presentation. So what happens when you have intravascular hemolytic anemia is all the consequences of this entity. And you can see that a lot of those symptoms, I mean, unless you think about testing for PNH, they can occur in multitude of disorders, right? So thrombotic events, kidney failure, pulmonary hypertension, all occur because of intravascular hemolysis and perhaps the formation of thrombi system-wide, and they have an impact on survival, whereas all the other manifestations with anemia, resultant fatigue, smooth muscle dystonia, which happens because you scavenge the nitric oxide by the free hemoglobin that happens to be intravascular, giving you symptoms of abdominal pain, dysphagia, erectile dysfunction. So it's a difficult disease to think about. And when you think about the impact on survival that you see here, and this is taken from the Leeds group, granted, this is sort of out of historical interest, but in reality, we didn't have any natural history changing medicines at that time. So for people in their mid-30s to have a graph like that compared to that of general population meant that this disease had a lot of impact on survival with 5-year mortality of about 35%. When I was at Rush, I collaborated with the MDS and Aplastic Anemia International Foundation to understand from the patients what was their path to diagnosis, those patients that were ultimately diagnosed, how was that journey? And it was actually remarkable to see that the majority of them had seen up to 5 physicians during the course of their symptomatology. And interestingly, only 13% were referred to hematology. The majority were evaluated by emergency room physicians from the get-go or primary care doctors. Even some were sent to mental health providers because nobody knew what was going on with them, and they thought it was, psychological. But in reality, so it can be actually a difficult disease to diagnose, and it can take some time. And in that analysis, when we asked this 200 patients how long it took, fortunately, the majority of patients were diagnosed less than 5 years from the onset of their symptoms, but a quarter took a little bit longer than that. And I think those numbers are a little bit better than what we have in the literature, which suggests that it may take up to 10 years until making that diagnosis. So as physicians, we really should think about PNH testing as per the Clinical Cytometry Society guidelines that were published in 2010. And I think of them as 3 different buckets. One is DAT negative intravascular hemolysis, in which after you've ruled out everything that may lead to that. So it shouldn't be your number 1 test, but if you have unexplained hemolysis together with iron deficiency symptoms, thrombosis, cytopenias, or acquired DAT negative hemolytic anemia. If you have someone who has thrombosis with unusual features, a classic one is Chiari. I think PNH has to be tested, but similarly, JAK2 has to be tested too, because a good number of those patients with Chiari would have JAK2 mutation. And the third category would that be of the bone marrow failure, where patients who have aplastic anemia or hypoplastic MDS, or even those who have cytopenias with no plausible explanation ought to be tested as such. So what do we use? Well, it's a blood sample from the peripheral blood sent for flow cytometric analysis, looking for those missing proteins that lead to the actual disorder, that is CD55 and 59. And then we also look for the white cells. Now, CD55 and 59 monoclonal antibodies don't work so well with the white cells, so we end up utilizing what is known as FLAIR, and this is essentially referencing the fluorescent proaerolescent. It's a bacterial product that identifies the GPI anchor, so it became sort of important to utilize to identify white cells that don't have that GPI anchor. And it's important to also make sure that physicians understand that you don't just look for the red cells, because sometimes they can be missing or destroyed, but a much better reflection of the PNH clone would be by looking at the white cells. Here is a scattergram of flow cytometry of a patient who had this disorder. So to the left is the FLAIR test, and you can see how it's gated to CD24, identifying granulocytes, and then we're looking at how many cells have FLAIR binding, and in this corner, those cells aggregate because they have neither. And that's your PNH clone, essentially calculated at 80% of all cells. Those are normal granulocytes that have CD24 and express, obviously, GBI anchor. And here's how you do it when you want to look at the red cells. So these are all glycophorinate positive cells, and you're gating them, or actually looking at the presence of CD59 in those cells. So the more CD59 that references type 1, which is considered normal. Type 3 is when you have a complete deficiency of CD59, comes closer to the 0. So that's your type 3 cells with no CD59, and that tend to be exquisitely sensitive to hemolysis. Now there's another type of red cells that expresses perhaps some CD59, and they are known as type 2 with partial deficiency. And it's said that if you have a lot of patients who have more type 2 cells, that their disease tends to be a little bit milder than those who have complete deficiency in CD59. We've already talked about the fact that a PNH comes with a bone marrow failure flavor, and then the International PNH Interest Group, also known as IPIG, try to come up with a classification for PNH, and you can think of it as a spectrum. On one end, you have classical hemolytic PNH, as you see here, and on one end is the subclinical PNH that's manifested in the setting of bone marrow failure, like aplastic anemia. But there is also a group in the center, which I think is a little bit harder to tackle and has to be evaluated on a case-by-case basis, whereby you have some features of bone marrow failure and some features of hemolytic anemia or classical PNH. So a few years ago, a couple of years ago, actually I should say, I was a PNH national coordinator, and we looked at, together with other investigators in the registry, which houses more than 4,000 patients, maybe 5,000 patients with PNH. We wanted to understand, is there a difference in the clone size relative to the clinical presentation? And so here to the right is the clone size percentage in patients who have bone marrow failure, and to the left, those who have high disease activity, meaning hemolysis and symptoms of PNH. And we looked at it with 3 different categories of PNH clone size. And you can see, I think it's easy to see that people who have high disease activity tend to have a much higher propensity for having a larger PNH clone size, opposed to those who have bone marrow failure, whereby the majority of them have small clone size. But you can also see all those other colored areas right here, which means that there's some degree of overlap. But granted, you could expect a higher clone size with hemolytic anemia, and similarly with major arterial vascular events as well as thrombotic events, you could also see much more prevalence for those events to occur in people who have clone sizes greater than 50%. And not to say that they couldn't happen otherwise, but the chances are less. So what do we do about this disease, and how do we treat it? Well, I mentioned supportive care because often patients don't respond to anything, or if they have bone marrow failure, you need to resort to transfusions. One word of caution, we need to always check for nutritional deficiencies because those patients tend to be iron deficient by the mere presence of hemoglobinuria and loss of iron in the urine, as well as folate deficient because of the hemolysis and the increased need for folic acid. Sometimes they can have kidney insufficiency because of kidney damage from chronic hemolysis, and you may need EPO. We used to use prednisone before we had complement blockers because we had nothing else to offer those patients. Allotransplant is reserved for a certain subset of patients that may have bone marrow failure, but generally not recommended for people who have hemolytic PNH. And then complement inhibition tackles the actual pathophysiology that leads to this disease, even though it's not curative, but at least it stops the hemolysis that goes on, reduces the thrombosis. And we have 3 available drugs, eculizumab, which was approved in 2007, and ravulizumab in 2018, and pegcetacoplan, which is a C3 blocker, which is approved in 2021. And there's a whole slew of novel agents that are ongoing in clinical trials for this subset of patients. And you kind of wish that you have that many drugs for many other entities that we have that have no good options. Nevertheless, treatment goals are to correct the anemia, reduce the risk of thrombosis, and improve quality of life. So we have to think about our patients that are being treated and whether or not our treatment actually is doing all of the above. As I've already alluded to it, classical PNH, I think, is the easiest category. Once your patient is hemolyzing, has a large clone, you want to prevent the thrombotic events, and I think it's reasonable to consider complement inhibition. Transplant is only considered if those patients do not respond or develop bone marrow failure. And then for subclinical PNH, I don't treat it as PNH, I treat it as a bone marrow failure. So if aplastic anemia, then immunosuppressive therapy, and I monitor the clone size every 6 to 12 months, depending on the situation. So monitoring actually is very important. And then the cases that happen in between, I think, have to be taken on a case-by-case basis. Often you monitor the patient for a while, and then you have to use your clinical judgment as to when you pull the trigger and begin treatment. So what is the site of mechanism of action for the drugs that we have available? Well, eculizumab and ravulizumab are both C5 blockers, and hence they prevent the formation of MAC and significantly reduce intravascular hemolysis. Now, one other concept I want you guys to understand is the extravascular hemolysis that occurs when you use C5 blockers for quite a bit of time. And now you have red cells that have C3 coating, and they end up being taken by the spleen in fashion very similar to DAT positive hemolytic anemia, and that is known as extravascular hemolysis. So if you're a patient with PNH who was DAT negative turns DAT positive, provided you do check it, then you know that you are dealing now with extravascular hemolysis. And for that reason, pegcetacoplan was developed so that it can block the complement at a higher up point. So that would limit the chance of developing extravascular hemolysis because of C3 coating. And then the novel agents that I told you about all tend to be oral, and at least the factor B and D inhibitors. And again, the point here is to actually reduce even the formation of C3b. So you're blocking the cleavage of C3 even at a higher up at the complement cascade. And it would be very interesting to see the results of the clinical trials that are evaluating that those particular compounds. So what is eculizumab? Well, it's a human IgG4 monoclonal antibody that has a complementarity region that recognizes C5. So each monoclonal antibody tends to pick up 2 C5 molecules. And this was evaluated in 3 different clinical trials, the initial pilot study, then the TRIUMPH, which was the pivotal trial, and it was double-blind and placebo-controlled in patients who had transfusion dependency. All those people were transfusion dependent, And then ultimately the Shepherd, which was a broader patient population. All of those three trials ended up in a long-term extension looking at the safety and tolerability of this agent, because there was a huge deal of concern about blocking the complement forever, essentially. And so that was very important, not only to look at the long-term extension, but also to have the registry to follow those treated patients and see what happens in this disease. Well, it was very effective to block C5, and you can see that half of the patients that were on eculizumab achieved transfusion independent versus 0 of patient on placebo, which is not surprising. But I'll make you aware that people who required 15 to 25 units of blood prior to enrolling onto this trial, even though they received eculizumab, they still required some degree of transfusion. And the same thing happens in the cohort of patients that required more than 25 units of blood. So eculizumab is great in controlling intravascular hemolysis, but if you have an element of bone marrow failure, then the drug will not completely abolish transfusion need. And this is the LDH. I think most of you have seen this graph. So in yellow and also brown are the Shepherd and the Triumph trials where patients received active therapy with eculizumab. And you can see the reduction of LDH was remarkable, and it happened in the first week, essentially. So those drugs worked very fast, and then LDH remains kind of suppressed throughout the treatment. In the blue are the patients who were assigned to placebo, and then at 26 weeks, then they were offered, moved down to the active arm, and then again, the same thing happens, their LDH drops precipitously. So this is why this drug became available and FDA approved, and actually the follow-up data from Kelly 10 years later showed that, look, at the survival of those patients approximate that of the age and sex-matched general population, which is a huge departure from what we knew about this natural history of this disorder. So that was a triumph in by itself. Now, ravulizumab was developed because to allow less frequent dosing. This is built on the backbone of eculizumab. It also binds C5. The only different thing about the ravulizumab is that it has a longer half-life. How does it do that? Well, it has much more enhanced binding to FcRn. So it gets into the endosome in acidic environment. It dissociates from C5 that gets destroyed ultimately, and then it kind of goes back into the circulation again. And that's how it has 4 times the half-life of eculizumab, and that's why it can be given every 8 weeks rather than every 2 weeks. And it's also weight-based, so that kind of took care of the variability in weight, unlike eculizumab, which is fixed dosing. And I'm aware of trials that are evaluating a sub-Q version with ravulizumab. The drug was compared to eculizumab in 2 clinical trials that had already been published in treatment naive and in those that have already been on eculizumab. And you can imagine in the treatment naive, that these were fairly large clinical trials. And the idea was to see transfusion avoidance and hemolysis in the treatment naive. And in people who had already been treated that were randomized 1-to-1 to ravulizumab versus eculizumab, the idea was to see, is there any change in control of hemolysis? And so those people were rather well controlled on their eculizumab, and then they were switched onto the new drug. Now, importantly, both trials were non-inferiority. And to make a long story short, in both trials, be it treatment naive or treatment experienced, the primary endpoints were all met. They met the non-inferiority margins, basically. And so you could say that both drugs are equivalent, essentially, in terms of disease control. And their side effect profile is actually very comparable, with the headache being the most common, nasopharyngitis, but for the most part, the drugs are well tolerated. Now, you do know that we need to protect against meningococcal infection because you're blocking the terminal complement pathway, and that's required for encapsulated organisms. So everybody should either be vaccinated or treated with antibiotics for 14 days until their vaccines kick in, including group B meningococcal vaccination. Now, one piece that was found to be rather interesting in patients who were treated with ravulizumab is this concept of breakthrough hemolysis. I've told you about intravascular, extravascular, and now there's breakthrough hemolysis. So breakthrough hemolysis happens when you either don't have sufficient blockade of C5 or when the complement activates and generates more C5, essentially. So one way to know if you have sufficient blockade is to measure free C5. So if it's below 0.5, then you are adequately blocking your complement. And importantly, when people compared the events with breakthrough hemolysis in both ravulizumab, eculizumab, and in both trials, you can see that the number of patients who have free C5 was basically non-existent in either trial when they were treated with ravulizumab. So it's believed that ravulizumab provides much more sustained, complete inhibition of the complement system. And so you could argue that, even though those were non-inferiority trials, you could argue that breakthrough hemolysis is less encountered with ravulizumab. It's not to say it's non-existent, because you still had breakthrough events with infections in both arms to an equal percentage. So, but generally speaking, perhaps because of the dosing or half-life, you have better C5 blockade with ravulizumab. Here's a patient that I had treated, and I thought it would be fascinating for you to see. In 2005, when we had nothing else, they were treated with steroids only. And then when eculizumab became available, this is essentially their LDH, and you can see how it kind of dropped precipitously and stayed there. On the other hand, here's what happened to their hemoglobin. So yeah, there was an improvement in the hemoglobin after initiation of therapy, but then the patients remained anemic with hemoglobin hovering at the 10 grams. So residual anemia after initiation of C5 blockade is a real problem that we have to deal with. And so what could be done that will help us? I'm not sure I can advance. Here we go. So residual anemia have been reported actually by other investigators, and this is a retrospective analysis from the UK PNH National Service, where there's only 2 centers that deal with PNH patients and okayed the initiation of therapy, unlike what we have here in the States. So they had 141 patients, and they noted that 3/4 of them had anemia, and some actually were transfusion dependent. So even though those patients were treated, appropriately treated, they still require transfusions. And in fact, a subset of them required higher dosing. So normally you get 900 eculizumab every 2 weeks. Now they're getting 1,200 or 1,500, sometimes weekly, to control their hemolysis. So anemia is something that we have to evaluate post initiation of C5 blockade. And you have to think about the various categories that can lead to this anemia. It's not just a breakthrough hemolysis, it's also bone marrow failure, insufficient dosing. There's an entity known as C5 polymorphism. This could be a board question, and that might lead to patients actually not responding to C5 blockers because they have C5 polymorphism, so the drug actually cannot bind to C5. Fortunately, that's not very common. It's typically in the Asian population, and even there, it's really rare, and it was noted actually on the clinical trials, but it's something we have to think about if your patient totally did not respond. And then, of course, this extravascular hemolysis, which is because of the C3 coating, as we will talk about in a moment. I also did an analysis of patients that were treated, and this was published just recently. And what we did is that we took 100 patients that had been treated with either eculizumab, ravulizumab, and compared their hemoglobin value to what they had at baseline. So in blue is baseline, and the yellow is follow-up, and looking at how much transfusions did they get and what was their hemoglobin at baseline and after treatment. So here again, you could see that even though you are treating those patients, not everybody is reaching normal values. In fact, those that are above 12 grams at follow-up represent only maybe a quarter of the patients, but there's no doubt that you have tremendous improvement in the hemoglobin with treatment. So you can expect to have normalization of the hemoglobin. On the other hand, you need to work up patients who have that type of anemia. So, and here is the new concept that we are faced with now in treated patients. Under normal conditions, you have decay accelerating factor, CD59, but in a PNH erythrocyte, because of the membrane attack complex, it gets destroyed, right? Now, because you're preventing membrane attack complex from happening, you have all those red cells that have the C3BB and C3b, or the fragments of C3 cleavage tethered onto them. This is what causes your DAT to be positive, and this is what causes extravascular hemolysis. So all of us knew that this was operative in PNH, yet none of us expected, or perhaps some of us expected, the degree of improvement in hemoglobin if you were to utilize a C3 blocker higher up, complement blockade. And this is what happened with the pegcetacoplan trial. So this is a C3 blocker that was compared to eculizumab, and in this phase 3 study. And then the idea was to see at 16 weeks of pegcetacoplan monotherapy compared to eculizumab monotherapy, what does the hemoglobin look like? So patients who were enrolled had to have a hemoglobin below 10.5 and had to have at least some transfusion with their disease. And so let's see what were the results of this randomized head-to-head comparisons. So this is the run-in period where patients actually had, because they've already been on eculizumab, they had to have pegcetacoplan to build it up to a reasonable PK level for 4 weeks, after which then you see the randomization and the outcome of the randomization. So those who were randomized to pegcetacoplan remained at right around 11.5 or 12, whereas those who were put back on their original drug, eculizumab, dropped to their relatively original level and perhaps lost a little bit more hemoglobin. So the difference at 16 weeks was statistically significant, and this proved that actually higher up complement blockade with pegcetacoplan is superior than eculizumab because of abrogation of extravascular hemolysis. Now, obviously, this is a sub-Q injectable, so injection site reaction is likely to happen. There's some reports of GI discomfort, diarrhea, etc., that may have led to treatment discontinuation, but in a very small proportion of patients. But the essential piece that is important is breakthrough hemolysis, and that is a piece that we continue to monitor moving forward with this agent, because now you're increasing your defective PNH cells and not being destroyed extravascularly. So the clone size in the red cells is drastically increased. And if you have breakthrough hemolysis, it's likely to be significant. So it's kind of an important piece that we kind of have to monitor with this patient population. The 48-week data also were published, presented at EHA by De La Tour, and it's showing the robustness and actually the stability of the response when patients are receiving pegcetacoplan. So, but again, these are 48-week data. I think we need a little bit longer to be sure that this actually is a reasonable pathway to follow. Now, just in case those 3 drugs were not enough, this is a list of all the novel agents. You can see how many C5 molecules are being developed. One of them, crovalimab in particular, is in phase 3, and actually it does work against the C5 polymorphism because it has a different epitope of C5 that it binds to. So that's kind of an interesting compound to monitor. There are 4 alternate complement pathway inhibitors, 3 factor D inhibitors that are being developed, and 1 factor B. Iptacopan, and like I said, all of them tend to be oral. So it will be hugely interesting to see if indeed PNH therapy in the future is going to be oral, not infusional or sub-Q for that matter. I just wanted to show you a couple of data points from both drugs that are being explored. Iptacopan is a factor B inhibitor, and there was a, prior to this trial of phase 2, there was a another phase 2 study of adding iptacopan to eculizumab, and then people notice that even after you stop the drug, patients continue to respond, and that was the impetus for trying monotherapy in patient population. And of course, this is a very small trial, but there are much larger trials that are being planned with this agent. And I would love to be able to participate in those studies as well to see if oral therapy would be of benefit to those patients. The bottom line is that monotherapy did the job. So it reduced LDH, improved the hemoglobin, improved all the hemolytic parameters, and reduced transfusion requirements. And the side effects were mostly headaches, abdominal discomfort, but again, you have a very small patient population. The Nicopan, on the other hand, is a factor D inhibitor. Now, factor D is what actually cleaves factor B. So factor D has only one substrate, which is factor B, and that's why it's very interesting to develop antibodies or inhibitors to that molecule. So this also was a phase 2 trial of danicopan monotherapy. Again, it's the same story. They had tried it as an add-on, and I was participating in the trial with add-on danicopan to eculizumab, again, in patients who have suboptimal response to see if you can improve the anemia, likely due to improvement or suppression of extravascular hemolysis. And here is the same exact story. Danicopan monotherapy reduced LDH, improved hemoglobin, improved fatigue, and was rather well tolerated. So this is how the clinical trial, just to show you the results. So those adult patients that had hemolysis, and this is in the treatment naive. And you have two different cohorts of dosing with monotherapy. And then the published data in Blood Advances is the result of interim analysis of this trial. So you can see compared to baseline, here's the LDH, significant reduction in LDH in either dosing cohorts, hemoglobin improvement in both dosing cohort compared to baseline, and look at the tremendous reduction in the number of transfusions that was done as the result of treatment with the agent, again, at either dosing. So I think that is what formed the basis for moving on with phase 3 studies. And it will be very interesting to see what happens. Again, all of those agents, while very effective, we will need long-term, not only efficacy, but safety data. And remember, now you have an oral pill, so now you're going to have to deal with all the consequences of drug interactions and absorption and PK levels. So we're going to need a whole lot more, but certainly from the get-go, even though the trials seem to be small, but both drugs seem to be, pardon me, rather effective in controlling this disease. I think, if you ask me my opinion, I think that we perhaps could sequence therapy. Maybe we have various ways to treat this disease, because do we really need to block the complement consistently and completely? Perhaps we could do blockade of the intravascular hemolysis and then add on other drugs. And these would be concepts that we'd have to write and explore with our patients, where you would add short bursts of treatment with an alternate complement pathway inhibitor to see if maybe you could restore the hemoglobin in this patient population. Not to forget talking about stem cell transplantation, which I have actually resorted to in 2 or 3 patients of mine that had been treated with eculizumab. All those patients were young and had been transfusion dependent. They did have a large PNH clone size and were treated with complement blockade for years, actually, with not enough response. And then ultimately, this young patient, after she finished college, opted for transplantation. And you can see the tremendous improvement in her blood parameters, and it occurred actually 3 months after transplantation. She had literally very little GVHD to deal with, and here's her platelets. Again, she was platelet transfusion. She had bleeding complications, not so much platelet transfusion, but again, you can see 3 months after transplant, everything normalized. And so there is no doubt that stem cell transplantation is a curative treatment option for patients who manifest with PNH. So I think that takes me to my last slide, and then I'll open it up for questions. So I hope that I had conveyed to you that PNH is a rare entity that is characterized by intravascular hemolysis, bone marrow failure, and propensity for thrombotic events, that the diagnosis can be delayed due to its rarity and nonspecific presentation, that the outcome of this illness have improved significantly with availability of complement blockade, that we have 3 different agents, C5, 2 C5 and 1 C3 blockers that have been approved for the treatment of this entity, that we need to monitor patients for residual anemia and need for transfusion and determine, is it a bone marrow failure, nutritional deficiency, or extravascular hemolysis? And obviously, stem cell transplant is reserved for patients who have PNH bone marrow failure, and that we need to get our patients to participate in trials evaluating novel agents, as this may actually be the way of the future for this disease. So I thank you for listening, and I will take questions should you have any.
Hi, Jamile. Thanks, Dr. Shammo, for this very elegant talk. It's a very rare disease, but very interesting and complex. I especially applaud you for really a nice review of the complement system, which for those who are afraid of the coagulation system, I think the complement system is even more difficult sometimes to understand. So that was very good.
Thank you.
So I think I have one question in the chat already. If anybody would like to ask their questions out loud too, feel free. Let me just read this from Dr. Sulla. He's complimented this great talk, but said, could you comment on the impact of PNH treatments on patients' fatigue and quality of life?
Thank you, Dr. Sulla, for this question. I think that the quality of life in patients who were treated with C5 blockade was remarkable, and it's very important to understand that it's not just tackling the disease. It's extremely important to improve someone's quality of life, and that was actually laudable in that part was included as an endpoint in the clinical studies evaluating PNH therapies, because in the end, that's what matters. Fatigue and quality of life was extremely reduced in this patient population. And so in the TRIUMPH study, they included certain measures of quality of life. I believe it was ERTC, the 30 questionnaire that was included in that. And then there are a lot of other quality of life measures that are being developed specific to PNH, because those that were utilized in the TRIUMPH trial and others weren't necessarily made for this patient population, but I think they applied and they appear to be statistically significantly different, when you compare placebo to active therapy. But I'm glad you asked, because I know that various groups have been trying to develop PNH-specific quality of life measures, and those are likely to be utilized in future clinical studies. Thank you for that.
I have a question, Dr. Shammo, in case if there are no others right now. I think, we know we implicate the complement system in this disease and some other rare diseases that we deal with. And I think really measuring whether we have complement overactivity is difficult. And I wonder, you mentioned measuring C5 as a marker of whether the complement system is being actively or effectively inhibited. Is that the measure that you typically use, or what would you recommend? I think, or in the clinical trials, are any of these complement activity measures being used as
Yeah, so unfortunately, the treating physicians are left on their own when it comes to that. It's sort of a clinical gut as to whether your patient is developing intravascular hemolysis, breakthrough hemolysis. So I wish we had ability to measure C5, but that's not available nor possible. Only if you go to ask, the company who made the drug, which I think we would need to develop a certain test that we would rely on, as opposed to a standout that's not necessarily available in like a core lab or something. So, but it would be great if we can have C5 measurements. We don't. I know some research labs have a way to measure the MAC, the C5 to 9, but again, that's not available to everybody. So what do you do in reality? You look at hemolytic parameters, you look at reticulocytes, you look at haptoglobin, you're looking at the LDH. Some places do CH50, to see whether or not you have ongoing hemolysis, but I don't find this to be helpful in the immediate setting because you need a decision right there and then. So ultimately we end up, if we believe that there's intravascular hemolysis going on, you might work with upping the dose. And that was operative in eculizumab because you could play with the dose a little bit since it was given every 12 days plus minus 2 days. So you could work with the duration, with the dosing, but that's not possible with eculizumab, I'm afraid. And with pegcetacoplan, I think you have a whole new set of regulations that come with that. So it is a difficult question to answer, but I think we tend to utilize hemolytic parameters, and sometimes I would do urine analysis to see if there's actually hemoglobinuria that would be indicative of intravascular hemolysis before I increase the dose. So I hope that helps.
Yeah, no, thank you. I know there aren't any good answers to how do we assess the complement system. So yes, but your insights are great. Any other questions out there in the audience?
Hi, this is Marge. Can you hear me?
Yes.
Hi, Dr. Shammo. It's so good to hear from you again.
Hi, Marge.
Welcome to Northwestern. I actually had a question. Would you say that there's a strong correlation or propensity for patients who are anemic and are typically transfusion dependent to move over to stem cell transplant?
I would agree with that. And Marge was my data coordinator actually at Rush. So good to have you. So
thank you.
Basically, I think typically patients who have anemia, I mean, it's not just intravascular hemolysis. There's an element of bone marrow failure. And that is also very difficult to quantitate. But if you have someone that you treated and now they don't have elevated retic count, so essentially you've controlled this hemolytic piece and they continue to be anemic and they're DAT negative, you might argue, well, you haven't really done flow cytometry because flow is what everybody has been utilizing to look at extravascular hemolysis, to look for C3 coating on red cells. And let's argue you don't have that. Well, then the only other possibility is that of bone marrow failure. And generally, though, if this happens, it's not just the anemia. You will have thrombocytopenia, you may have neutropenia, infectious complications. And so the evolution to bone marrow failure state, to aplastic anemia, despite therapy, is going to be what makes you want to do transplantation. Did that answer your question?
Yeah. Thank you so much.
Thank you.
Okay, perfect. Any other questions out there in the audience? One last question, maybe. I think early, sorry to bring COVID back into this. I know early on in the COVID pandemic, there was, the concern about complement overactivity actually, and it being a problem with disease pathology. And actually, if you inhibit complement system, patients sometimes potentially did better. Is there any experience in the PNH population and those patients who are on complement inhibitors and their experiences with COVID?
That's a great question, Anna, and it's actually very pertinent to today's issues, right, with COVID. I think all typically for all of us, patients with hemalignancies, even ITP, right? We always say that you include PNH included in this group, obviously. Everybody needs to receive COVID vaccination. The problem is that there had been cases of breakthrough hemolysis that had happened in PNH patients despite therapy. So I would monitor those patients. I'd make sure that they get their COVID vaccination in the first week after therapy, because that's when you're likely to have the highest PK levels of the drugs that they have on board, and then monitor them accordingly. But it has been reported, though it's not sufficiently for me to say, don't do it, so we do it and we monitor the patients accordingly. Thank you.
Perfect. Okay.
Well, Jamile, thanks so much, and welcome to Northwestern.
Thank you very much.
Thank you.
Thank
Thanks,
you.
everyone. Next week we have Dr. Tallman, so come back for that. We'll send out information this week. Thank you so much.
Have a
Dr.
wonderful
Shammo.
weekend.
Bye-bye.
Bye.
Thank you.